Good afternoon, everybody, and thank you for allowing me to present this one, the assessment of tricuspid valve. So, agenda of the day is why assessment of the tricuspid valve is required and whom to assess for the tricuspid valves, anatomy of the tricuspid valve, transthoracic views for tricuspid valve assessment, transesophageal views, tricuspid regurgitation, which is the most important thing regarding the tricuspid valve, the tricuspid stenosis to some extent, and some tricuspid pathologies, and some transcatheter tricuspid interventions. So, tricuspid valve is regarded as the forgotten valve, and we all know when we try to forget something that causes the most miserable part of our life. Tricuspid valve develops in the fifth to sixth week of embryonic life. It's very early. And secondary tricuspid regurgitation, which is the most common pathology of tricuspid valve, is an important independent predictor of mortality in the surgical, percutaneous, and heart failure population, which is growing day by day. Transcatheter interventions of tricuspid valve is increasing, though it is causing, because for the transcatheter interventions, proper imaging is required. In spite of this growing interventions of the tricuspid valve, there's a lag between the tricuspid valve involvement, which includes around 1 lakh 20,000 people being affected, while only 8,000 per year tricuspid valve interventions are being done. In spite of growing tricuspid valve interventions, there is still the approach is wait and see approach for the tricuspid valve. So, one case scenario, a 28-year-old male presented with low-grade fever for 2 months, who has been investigated extensively by various departments for the fever, and then went for an echocardiography. The echocardiography, they found some mobile vegetations, which mobile mass present in the tricuspid valve. When a proper RV view was made, a vegetation was seen. And when a T was performed, a vegetation, as well as along the pacemaker, there was a history of pacemaker implantation, which years prior due to the congenital heart block. It was found the vegetation along the pacemaker lid. The second case was a 10-year girl who presented with recurrent cough and cold, and there was dilated right chambers with tricuspid regurgitation. And on seeing the tricuspid regurgitation, which was found, it was not only due to the which was secondary to the RARV dilatation, which was secondary to the intraatrial septal defect. So, for why tricuspid valve assessment is necessary? Tricuspid dysfunction is associated with left-sided heart disease. Dysfunction tricuspid valve is responsible for increased mortality and morbidity. Repair or replacement of tricuspid valve is more complex and is associated with guarded outcome. Better understanding of the tricuspid valve is necessary for better outcome in days. Whom to assess? Patients with right heart failure symptoms like features of ascites, dyspnea, fatigue, and those who have the pulmonary hypertension in left heart pathologies like associated with mitral regurgitation, mitral stenosis, or aortic stenosis, and pulmonary hypertension in cardiomyopathies, which are most commonly found in dilated cardiomyopathy patients, which are growing day by day, and the hypertensive heart failure patients also in HFpEF. Heart failure disease, right heart diseases like idiopathic pulmonary hypertension, pulmonary embolism, chronic heart failures, and the RV hypokinetias, which may be isolated as a result of right-sided myocardial infarctions or as a result of sarcoid or any other infiltrative disorders. So the anatomy. So tricuspid valve is an intricate configuration. The function depends on the synchronized coordination of its components, like the fibrous annulus, which is a dynamic structure whose diameter changes by 17% during the atrial systole. The fibrous annulus is such a thing which causes dilatation during the heart dilatation of the right side and thereby leading to functional tear, which is very common. Now the leaflets, the anterior septal and the posterior, the largest leaflet is the anterior, and the septal, which is the more tethered one, which is attached and less mobile, and the smallest one, and the posterior, which has number of commissures and is mostly variable. Now the chordae tendineae, which attaches the leaflets to the papillary muscles. The papillary muscles are two mostly, it may vary from 2 to 3. The papillary muscles are anterior and mostly posterior. It is attached to the anterior papillary muscle. The anterior and the septals are attached to the anterior papillary muscle by the chordae tendineae, while the posterior and the septal is attached to the posterior papillary muscle with the help of the chordae tendineae. The chordae tendineae can be remain attached directly to the right free muscle also, right free wall. There is a moderator band which attaches the anterior and the septal papillary muscles. Adjacent right atrial and right ventricular myocardial function is necessary for the proper functioning of the tricuspid valve, as we all know. More variable structure than the mitral valve, and thereby the imaging is more and more difficult. It is not a planar structure, and it is the largest valve with an area of around 4 to 6 centimeters square. It's not planar, but when it becomes dilated in tricuspid regurgitation, with dilatation occurs, it becomes more planar. It is usually a saddle-shaped structure. And as already told, it is upon the dynamic structure of the annulus. The annulus measurement is to be done in the four-chamber view with the in the diastolic period, and the diameter of more than 21 millimeter per meter square or more than 35 millimeter in the AC and more than 40 millimeter in the ACC has been recognized as to be dilated, annular dilatation. In spite of being measuring the major and minor, it is always underestimated. To look at the tricuspid valve, it lies slightly to the posterior and to the right of the aortic valve. It lies in relation with the interatrial septum. The important relationship is with the AV node. The septal leaflet forms one of the boundaries of the triangle of Koch, and tendon of Todaro lies posterior to the septal leaflet. Just to the anterior leaflet of the tricuspid valve lies the right coronary artery. The coronary sinus ostium, the opening, lies just posterior to the septal and posterior commissures. So the echocardiography and the tricuspid valve assessment, it is very difficult to assess for the by 2D, the tricuspid valve, as it's a 3D, three-dimensional structure and non-planar. But with the developing in earlier days, as more and more the tricuspid valve was assessed with the 2D with special views, which are mostly the pasternal short axis RV inflow view. From the pasternal long axis, if we tilt it slightly anterior when the coronary sinus is being visualized, we get to see the septal leaflet of the tricuspid valve and the anterior leaflet. It is being visualized in the 100% cases. Now, after the RV inflow view, then we come to the apical views. In the apical view, with the RV part being separated, we get to see the septal leaflet mostly, and the other leaflet which is sent is in case of 100% is the anterior leaflet. In case of 25 to 30% cases, we get to see the posterior leaflet also. Why it's important? It is important to visualize and identify these leaflets, though in some studies has shown that this is not very reliable, all these structures which have been delimited with these structures. It is important because the transcatheter therapies which are being given, it has to identify the leaflets properly and to get to see those things properly. So that when 3D came, it became the life easier because the 3D reconstruction could visualize which helped to visualize the leaflets better. So after cropping in the image, when we go into it and see the NFS view from the atrial side as well as the ventricular side, we can see. From the atrial side, when we can see the septal leaflet, the anterior and the posterior leaflet. And going by up and down and gradual visualizing it, we can see the tricuspid valve better. So this is another view in which tricuspid valve can be seen is the pasternal short axis view, in which the septal leaflet is seen in 48%, anterior, septal and anterior in 48 to 52%, and posterior is mostly seen in the lateral part. Next is the transesophageal echocardiography. In the transesophageal echocardiography, it's the four-chamber view at the 0 degree when we first see the RV side and the tricuspid valve. And then when focus it on the RV view with the tricuspid valve, we can see the tricuspid valves. Another view is the modified bicaval view in the 110 to around 120 when we go deep inside and then rotate and we can see the tricuspid valves. So when in the transesophageal also, when we go deep inside in the transesophageal, in the apical fourth chamber, if we just antiflex it by going, as it's not an planar structure, so by going up and down and gradually doing antiflex and retroflex, we get to see the views. When we antiflex it, we see more of the septal leaflets. And when we retroflex it, we see more of the coronary sinus, and along with that, we get to see the posterior leaflets. it is very becomes very difficult to quantify the tricuspid regurgitation in the TE when it is an RV site. So these are the other views. In transgastric, we again also we can see the tricuspid valve better with the 0 degree, and with gradual rotation at the 90 degree and the around 45 degree, we can see the tricuspid valve leaflets. So next comes the tricuspid regurgitation, the most important pathology of the tricuspid valve. The most important, around 8 to 10% is the organic tricuspid regurgitation, which occurs less, while the 90% is for the functional tricuspid regurgitation. Important thing about functional tricuspid regurgitation is the recent days, it's the isolated tricuspid regurgitation, which is growing in elderly patients, and we are getting it with the atrial fibrillation, which occurs as a result of the tricuspid valve annular dilatation and change in geometry of the atrium, right atrium. So TR as a result of elevated PASP occurs due to pulmonary hypertension, left-sided heart disease, which may be primary, secondary, and the valvular diseases and the cardiomyopathies. Tricuspid regurgitation can occur also as a result of fluid overload, RV failure, and renal diseases. Most common another functional tricuspid regurgitation which we are getting is due to the organic, which is due to the and iatrogenic, mainly is due to the pacemaker entanglement and the pacemaker dysynchronies. Pacemaker, as more and more pacemaker is being implanted, the tricuspid regurgitation is growing. Around 38% of the patients who are being implanted with pacemaker who has a trace to moderate turns out to be severe tricuspid regurgitation over a year of around 1 to 1.5 years. So when to assess for the tricuspid regurgitation, from the structural part, we can see the hepatic vein flow reversal in the hepatic vein reversal in case of severe. It is very sensitive but not very specific. Another is the density. Gradual, more and more, the denser the regurgitant jet, more severe the TR is. Again, is the severe TR by the triangular. More it becomes triangular, that is the early pressure equalization leads to a severe TR, indicates a severe TR. So the grading. So the grading from the structural, that is the tricuspid valve morphology, then is the RV and RA size. RA size of more than 18 ml per meter square. Then is the RV size, which is measured in the fourth chamber at the basal side of more than 42 and at the mid level around 35. IVC diameter, which is more than 25 millimeter, denotes a severe. Qualitative, which is the color flow jet area with a large central jet throughout the systole, and those which are impinging towards the septum, which are color denotes a severe. Another thing, these are qualitative color flow, which depends upon the hemodynamic changes. Another is the color flow convergence zone and the CWD. Semi-quantitative measures of which the vena contracta weight is an independent manner. Hemodynamically independent structure with more than 7 millimeter is defined as severe. Then is the PISA radius of more than zero point 0.9 and tricuspid inflow of E more than 1. The quantitative measurement of the ERO of more than zero point 0.4 and regurgitant volume of more than 45 ml. In this, which have to balance the Nyquist limit. First of all, let's go to the PISA radius, how to assess it. For the PISA radius to assess, we have to first an RV view and proper RV view from the apical fourth chamber, then concentrate the color to be given and the aliasing velocity to be fixed at around 28 centimeter per second. Then from the flow, 2 pi r square by aliasing velocity VA, in which r is the radius of the PISA. Then regurgitant orifice by Q divided by the Vmax. Now, by regurgitant volume attachment, we can go by regurgitant orifice of area into the TR-VTI. By assessing it, we can get the regurgitant volume. Another way of getting the forward stroke is the forward stroke volume. Regurgitant volume can be assessed by diastolic stroke volume minus the forward stroke volume. The forward stroke volume can be we can assess from the LVOT annulus area into LVOT VTI, which is easily done, and the diastolic stroke volume from the TV annulus area, which is a little bit difficult, and the TV VTI. So the regurgitant orifice area, regurgitant volume divided by the TR-VTI. Another very reliable method is the 3D color Doppler, from which the vena contracta area can be assessed, and from the regurgitant orifice area we get the vena contracta area, and the regurgitant volume area from the vena contracta area into the TRVTI. Now recently, though, it has been changed. After severe they put massive and torrential, because these were coming more. So the torrential was more than 21, more than equal to 21 millimeter of vena contracta. By 3D vena contracta area quantitative Doppler, it was more than 100, more than equal to 115 millimeter square, while EROA PISA was more than equal to 80 millimeter square. Massive and torrential was named accordingly. So the tricuspid stenosis, in which the pressure gradients were given a cutoff around 5, more than equal to 5 millimeter mercury, but it recently also we can get more than 7. Mean of more than 7 has been described as severe, and around 3 to 6 as moderate, and mild of more than 2 to 3. The VTI of more than 60, more than equal to 60 centimeter, PHT of more than 190 millisecond has been denoted as severe, and the tricuspid valve area less than equal to 1 centimeter square. The supporting findings are the dilated right atrium. Very few cases are there when tricuspid stenosis occurs. Tricuspid stenosis, when occurs due to rheumatic heart disease, is usually due to the associated mitral stenosis. It occurs as a result of carcinoid syndrome or as other causes of infiltrative diseases. Some more tricuspid pathologies like the Epstein anomaly, which is one of the most common congenital anomalies which we get. It is due to the apical displacement of the septal leaflet, in which more than 10 millimeter or more than 8 centimeter per millimeter square displacement of the septal leaflet is recorded as Epstein anomaly, and thereby there is more the displacement, lesser is the RV volume, functional RV, and more severe is the Epstein anomaly. Some more pathologies are the myxoma, the tumor polyps, which we get on the tricuspid valve. Then is the tricuspid prolapse, which occurs as isolated or as a part of the prolapse syndrome. Then is the ruptured chordae, the carcinoid syndrome, in which it occurs as an entire thickening of the entire valve, which occurs mostly of the right side, and the transcatheter approaches, the edge to edge, and the intravalvular coaptation devices, all these transcatheter approaches require a proper T support for the interventions to do as well. And though these are all, like the mitral edge to edge repair is much more commoner, tricuspid repair is being tried and trying to gain more and more importance. The valve-in valve and the valve-in valve is much more important. The caval valve implantation, which is growing for as aged patients are getting more tricuspid valve involvement, the caval valve implantation has been found to decrease the mortality and all, but no change in the pathology which is causing the tricuspid regurgitation. So it's also a growing perspective. So this was a visualizing the severity of functional TR, which decreased after percutaneous tricuspid annuloplasty with the trial and device. So the take-home message is meticulous assessment of the tricuspid valve is necessary. Echocardiogram is a good modality for tricuspid assessment, though the volumetric assessment is for which CMR is better. Isolated tricuspid regurgitation is a growing issue. With newer transcatheter interventions, assessment is needed. With growing heart failure incidence, requirement for tricuspid intervention is also increasing. Thank you.